Good morning. Today we are going to talk about female causes of infertility and specific polycystic ovarian syndrome. For the few last years, we realized that more and more women is coming in with the diagnosis of polycystic ovarian syndrome. In our office and part of our Wijnland team, we do have Dr. Morrison that did a master studies on this specific topic. And what makes this study so important for us is to also include teenagers. So we actually invited mothers to listen to this talk and realize that teenagers can also have the diagnosis of polycystic ovarian syndrome. Dr. Morrison, will you please explain to us what's the definition of polycystic ovarian syndrome and telling us a little bit more about your study?
Hi, so polycystic ovarian syndrome is extremely common. It affects about 10% of the population, and it's something that I think I speak about every day, a few times a day. So whether it's to adolescents who are having irregular periods, to women who are trying to fall pregnant, or patients who are struggling with insulin resistance and weight gain later in life. It's actually a terribly named disease. When you think of polycystic ovaries, you think of big cysts that are causing the problems. But actually, it's really, a cyst is just a fluid-filled structure on ultrasound. So a follicle, which has a house of an egg, is what you're seeing in what we're calling cysts in polycystic ovaries. So women are born with a certain number of eggs. And what happens normally is that each month a new cohort of eggs comes up, one will ovulate, and then you lose the rest of those eggs. In polycystic ovarian syndrome, you just have more follicles. And what happens is that basically the ovary becomes a really stubborn ovary and it stops responding well to the signals from the brain. So there's some dysfunction between the hormones released by the brain and how the ovary responds. So the two hormones that are responsible for ovulation are follicle stimulating hormone and luteinizing hormone. And what follicle stimulating hormone is, that is released by the brain in the first half of the cycle, and that gets one of those little follicles in the ovary to start to grow, to become a dominant follicle that then ovulates. And then in the second half of the cycle is when your luteinizing hormone takes over. In polycystic ovarian syndrome, what happens is that you have so many of those little follicles, more than average. And so all of these tiny little follicles are producing small amounts of estrogen. And that estrogen then sends a message back to the brain and says, we're good, we've got enough estrogen, we don't need extra follicle stimulating hormone. And so your brain makes the normal amount of follicle stimulating hormone instead of making more. And that then gets dispersed between all those antral follicles. And then in the end, one doesn't grow to become a dominant follicle and you don't ovulate. But the ovary wants to make hormones, and so what happens is that the luteinizing hormone stimulates the thicker cells in the ovary to start to make androgens. And that's when you start to get the side effects, the acne, because androgens are the male hormones, so that's when you start to get extra hair and androgens production. So there are a few things that are really important in polycystic ovary syndrome, and the one is insulin resistance. And in the study that I looked at, actually 70% of the teenagers and about 69% of the women over 35 presented with insulin resistance. So it's an extremely common. Not all the patients have it, but a vast majority. So it's key component to polycystic ovarian syndrome. So
Dr. Morrison, what I'm hearing is that insulin is one of the most important ones in polycystic ovarian syndrome. Is there also more symptoms that we pick up quite early?
There are. So why insulin is so important is that insulin allows the storage and the uptake of glucose. If you have insulin resistance, then what happens is that the pancreas starts to produce more insulin. And a high amount of insulin has two effects. The one effect is that it directly acts on the ovary, and it causes the ovary to produce even more androgens. And that's where you get even more of those symptoms. So the teenagers present often with the acne, with hirsutism, so extra hair, and that can be on the top lip, on the chin, chest, often a little bit of male pattern balding. So it's all the sort of androgen effects because of insulin resistance and because of the increase in androgen levels. The second thing that insulin can do is that it can decrease the production of sex hormone binding globulin. And that's a very important little protein that is produced by the liver. And what sex hormone binding globulin does is it binds free hormones. So if testosterone is bound to it, it's almost like it's not there and you won't have the symptoms. But if you have very low levels of sex hormone binding globulin, what you'll find is that you have a lot more of the symptoms of acne and increased hair production. So much more of the androgen symptoms. And that's why if you present to your GP or your gynecologist in the teenage years where you're presenting with acne, they'll often put you on the contraceptive pill. And the reason is just simply to increase your sex hormone binding globulin amount and therefore decrease your symptoms of the acne and decrease your free unbound testosterone. The other important component of PCOS is obesity, and very often a sudden increase in weight precedes the androgen production, or the teenage girls will present with a sudden increase in weight and then start to present with the acne and increased hair. Obesity, like insulin resistance, has also two effects on PCOS. And the one is, again, it lowers your sex hormone binding globulin rate, so you have more of that unbound free testosterone. And the second effect is that the fat cells start to produce estrone. And estrone is a form of estrogen, which then can be aromatase, or it gets converted to androgens. So again, if you have more androgens, your symptoms get worse. The other thing is that the low levels of estrogen that the fat cells produce also feed back to the brain and again add to the total amount of estrogen that feeds to the brain and says, no, we have enough estrogen, we don't need more FSH. And that compounds the problem because it worsens, it decreases the chance of you ovulating again. So how do you know if you have PCOS or if your daughter has PCOS? So there are certain diagnostic criteria that we follow, and these are called the Rotterdam criteria. And in order to say that you have PCOS, you need 2 out of 3 of the criteria. So the first one is irregular menses or irregular periods. So that can be skipping periods for long periods of time and then having a heavy bleed, or periods that can be 6 weeks or longer between cycles. For adolescents or teenagers, this can be quite common in the first 2 years after puberty. Because there's an immature hypothalamic pituitary axis, it's quite common to have irregular periods. So I wouldn't worry yet, but if it persists beyond that, then it is probably time to see your gynae and just have a checkup. Just because you have a period every 3 or every couple of months doesn't necessarily mean you're ovulating. What happens sometimes is that because of all that estrogen, the lining of your endometrial lining just gets thicker and thicker and thicker, and eventually it overflows, or sort of outgrows its blood supply and then overflows. And so you will have a heavy bleed, but it's not a bleed because you necessarily ovulated. So if you are having very irregular periods, it's probably worth getting it checked out. The second criteria is polycystic ovaries on your ultrasound. And these have certain criteria. So you need big ovaries that have more than 20 little antral follicles, and they have a very specific pattern. So a polycystic ovary, because we discussed earlier that the thicker cells start to produce more androgens, male hormones, so that you get this very thick inner part of your ovary, which is a hypertrophy, it hypertrophies, and then all the little follicles get pushed to the outside, and it resembles like a pearl necklace. So we call it the ring of pearl sign, and that's a typical polycystic ovary. You have to be very careful in making that diagnosis too early, because many adolescents or teenagers will anyway have a lot of follicles, so we call them multifollicular ovaries, but it doesn't mean that they necessarily have the whole polycystic ovarian syndrome. The other difficulty in diagnosing it in adolescents is that it's very often patients are not sexually active yet, and so we can't do an internal scan, which is the best way to look at an ovary. So we have to do a transabdominal scan from the top, and because obesity is prevalent in about 70% of these patients, often the resolution is very poor and it's difficult to make that diagnosis. The other difficulty in making the diagnosis of polycystic ovarian syndrome of the ovaries is that 20% of women who have regular cycles who don't have the hyperandrogenism will actually present and have a polycystic ovary morphology on their ultrasound, but they don't necessarily have the syndrome. And then the third criteria, which we've touched on quite a lot, is just the hyperandrogenism, and that can be clinical or biochemical. So what I mean by clinical is that you would present with acne, the excess hair, the male pattern balding, and biochemical is that your gynae or your GP might do some blood tests, and you'll see that there'll be increased androgen levels, so higher levels of testosterone, and free androgen index will be raised. So those are the important ones. Again, you have to be careful in the adolescents or teenagers, is because going through puberty, acne is very often a transient thing. So if it lasts the first 2 years after puberty, you're experiencing it, I wouldn't stress too much. But after that, if it's something that persists, it's definitely worth checking it out.